much. And thank you for such an amazing talk. I would very much like to say that there's so much intersection that goes on with everything that you just talked about in terms of patients taking it upon themselves to come up with solutions that are tangible and physical and improve their health, to those of us who have diseases that there may not be some type of solution that you can come up with, but we need that same space for our emotional health. And we can drive innovation just by being connected with each other. And I think that's a lot about what I'm going to be talking about today. As was mentioned, I'm really going to focus my talk today at my intersection between patient advocacy and genomics research. You're going to see a picture on every single slide of a patient that I work with, and I work with thousands of patients every day. And it's a reminder, we constantly remind ourselves that they are not data points. Every patient is an entire universe. So 6 years ago, I was diagnosed with this really terrible disease called Angiosarcoma. And I was just about to get my PhD, I was a scientist, and so I understood PubMed. I understood how to look at the literature. And I went and found almost nothing. There was nothing known. There's a couple hundred people a year who get this disease. And why would anybody study it, right? It doesn't make any sense for people to actually study it. So when I went to PubMed and there was almost no basic research, what I found was this Kaplan-Meier curve right here. Kaplan-Meier curve shows the death rate, basically, the survivability. And as a scientist standing at the precipice of that curve, I felt vertigo sink in, like nobody's business. It was horrible. You look down and you realize that I'm going to die, and I'm going to die really fast. And so as a scientist, I knew it was a dead end, literally. And I couldn't go further because I couldn't get money to study it. I couldn't stay alive long enough to study it. And I thought the best thing that I could do at that point was just try to make that human connection with anybody else who understood. So I turned to Google, and I put in angiosarcoma cancer, survivor, and I found them. They were there, and I wrote to them, and nobody answered me. And I would then Google search their names. And every single time I did that, I'd find their obituary. And when that happened, it was like a black hole would open up and suck in every ray of hope. You can't imagine how isolating it is to be that desperate for that connection. And so I went to a super unlikely source for a scientist to go to. I went to Facebook and typed in angiosarcoma cancer, and they were there. There was 10 of them. And they were led by Lauren Ryan, and they housed the world's knowledge of this disease. They knew which doctors had heard of it before. They knew which treatments actually worked for them. And they were alive. And they gave me my hope back in spades. So this all went down in 2010. It was a very bad year, right? I was supposed to walk at commencement with my PhD. It was supposed to be a happy year, but there was an empty chair at my commencement because this happened like the week before I was supposed to graduate. So there was an empty chair with my name on it. And I decided that if I was going to go down, I was going to go down trying to put a dagger into the heart of the beast. And so with Lauren Ryan, we co-founded Angiosarcoma Awareness, which is a 501c3. And we decided our great ambition was to raise $10,000. Well, actually, let me back up. She started this whole thing, and her great ambition was to raise $1,000 selling bracelets and give it to the American Cancer Society so that they would figure out a cure. By a show of hands, is that going to work? Yes or no? Like, yes? How about no? It's not going to work. For those of you who are not willing to vote, it's not going to work. And I broke her heart when I told her it's not going to work. If you want to make impact, you can't even catch the attention of somebody without $50,000. And even then, what you're doing is you're getting part of a technician's time to study something. So you need to actually go somewhere where they're already sort of studying it and they don't know it yet, and then fund part of somebody's salary. And that was just a very hard reality for her and everybody else in our community to realize, but it was the truth. And so that's what we did. We set out and we embarked on the truth and started this foundation. And I realized that I was not gaining traction with the people that I needed to network with in order to find those people who may think they're, maybe studying something close enough to angiosarcoma to make a difference. And so I went ahead and defended, which was the scariest thing I've ever done because I had to give up my insurance to do it. And when you're gonna die and maybe need to be hospitalized to have decent end-of-life care, that's a scary proposition. But when you're also realizing that you may be the only person that can push this forward, it's worth it. And so I went ahead, I got the 3 letters, and it made all the difference. And it shouldn't, but it did. And it was this crazy thing. I kept not dying, even though I was supposed to. And because I was still alive, I decided, well, I know I can't study angiosarcoma. I understand the way funding happens. But the next best thing as a scientist that I can do is I can study something where if the following things happen, maybe I can pepper in a little bit of impact. If I live and I do a kick-ass job as a scientist, I might be able to then, at some point, with enough funding and enough clout in the scientific community, pepper on one little study of angiosarcoma. And that was going to be my career path. And again, by a show of hands, is that going to do anything for this rare disease? Yes? No? Right? It's not. It's really not. Like, got to be honest with yourself. Like, it would make me feel great to be a PI, right? And it'd make me feel great to get the tenure position and get those RO1s, and that would be awesome. But if it's not going to do anything to move the needle at all, and you have to just be real with yourself when your mortality is on the line. So I came to this crux, because the postdoc went really well. And I had a position waiting for me, and I had a K99, which is like the pinnacle of achievement that you could have. And I was like, you know, do I take it and run and study melanoma? Or do I just like take a step back and look at what we did through advocacy? And when I look at what we did through the research world, what we did was we came up with our own funding mechanism. We said, if you want our like piddly little $25,000 grants, you're gonna have to make a commitment in writing that you'll share your data with other people in the community. If you want our grants, you're gonna have to write the MTAs before we give you the money. So we know that that is an actual, legit, legal binding decision that you're engaging with us on. And as a result, these people that we've funded now collaborate with each other. Everyone over here on this map knows what everybody else has done. They know where they failed, which is probably the most important. And they've had successes where the lab that we fund at Sloan Kettering has published 3 peer-reviewed journals and has started a clinical trial. Didn't work, but we know now. You know, there's at least one failure. And what I found from clinicians in the community is through that failure, we know the baseline for this disease in a clinical setting, which was not known before. So even in that failure, we have a lot of information that we can use going forward. This is what we did as a community through the research. And what we did as a community, just by referral alone, is we actually made an expert in angiosarcoma, clinical expert. Before we came along as a group of empowered patients, people would go and they would be referred to sarcoma clinical centers across the country, and those centers would distribute each of the cases among their team. And so any one sarcoma specialist, even at Dana-Farber where I was being treated, may see 1 or 2 cases a year. You know, and these are high volume centers of excellence. So we started referring everybody to one doctor at MD Anderson, and he now sees 60 to 70 new patients with angiosarcoma every single year. And his entire team, from the scheduler to the nurse practitioners to everybody involved in that care team, understands anecdotally how to treat this disease. And the patients that are going there are living longer as a result. And they're taking that information and building care teams with their local clinicians so that they can be treated in their own community with the expertise that's gained as a result of this one doctor who's seeing the people in our Facebook group. So it's really lovely. So let me ask you now, again, by a show of hands, if you were me, right, facing your mortality with the experiences that you've had as a patient or as an advocate, how many of you would choose that scientific route that I had mentioned, by a show of hands? How many of you would just say, screw it, I'm going to be an advocate? How many people? I just need to see it, right? And so I chose to do both because this crazy opportunity popped up. It was an unbelievable opportunity at the Broad Institute where they wanted somebody who understood cancer research, who understood the perspective of the patient, who understood the nonprofit world, to come in and help them think outside of the traditional academic box so that they could launch these direct-to-patients initiatives and cut out the middlemen across the board to rapidly accelerate the progress that they could make in the space of cancer genomics. And at the crux of why they wanted to do this is these statistics right here. So only about 5% of cancer patients, and I think that's actually a high number, they're enrolled in clinical trials. And the vast majority of the tissue that scientists work with and our great vast understanding in molecular characterization of cancers come from these tissues. 85% of people are treated in the community setting. So that means that the vast majority of tissue is not being used for us to understand cancer. So that person that had an extraordinary response to a particular chemo in Idaho, that we'll never know why, right? Because that's just going to stay in a paraffin block on some pathologist's shelf somewhere, and it's not going to do anything to move that needle anywhere, right? But we live in an age, as everybody here well knows, of technology where that doesn't need to be the case anymore. We can use social media to get at least the bleeding edge of patients who are listening and wanting desperately to contribute to our understanding of disease, right? It's not everybody. It's not an actual cross-section of people who get the disease, but it's the people who are willing to carry the torch to other people and for themselves so that we can get a better understanding. And the Broad wanted to know, can we engage them and then engage a broader community of people so that we could just go directly to patients and partner with them? In October of 2015, I was brought on to help launch the Metastatic Breast Cancer Project, which we launched in October of 2015. And this is the approach that we took, was to make an online consent. Sounds really easy, right? Just an online consent so that no matter where you are in the country or actually in the world, you can just go to the website, sign up, and provide us your permission to get your medical records and your stored tumor blocks. And then we send out a saliva sample collection kit, and that enables us to perform very detailed genomic characterization, both whole exome sequencing of tumor normal matched tissues, along with RNA-seq for a little hint into the epigenomics of what may be causing this disease. We do this and we collect the medical record because we want to do a deep and rich clinical annotation so that we can understand people's responses to different therapies and their underlying molecular genotypes that may be contributing to those responses. The point of one of the major points of what we're trying to do here is generate a shared research database that can be used by the entire biomedical community in an effort to do away with the silos that most data go into. And so we're making this data available, and we're going to put it in basically any database that will have it. So we'll make it, we'll have our own that we'll build out, but we'll also put it in, the data commons, we'll put it in dbGaP, we'll put it in wherever people are clamoring for data to go, we're going to put it there as well. So when we launched in October of 2015, it was a big experiment. We had no idea what the response was going to be. We thought it was going to be good because from the very beginning, in the onset of this project, the first thing we did before we even wrote the protocol was we started to engage patients in the community. I have cancer. I don't have metastatic breast cancer. In my cancer, there are no controversial colors. And I won't say anything about what that means, but some may know what I'm talking about. In my cancer, there are not really many inflammatory words. I don't have to watch my step. But that's not the case in other cancers. Other cancers have their own unique culture and ways of talking about their experiences. And I didn't know that until I started doing cross-advocacy, because I only knew about my own. And I was enlightened when I started talking to people with metastatic breast cancer to figure out what was important to them. And so we talked with them and we asked them, how does this message sound? And they're like, it sounds horrible. I have no idea what you're talking about. And we said, well, how would you say it? And they gave us what they would say. And that's what's on our website. And we said, how does this picture look? And they're like, that looks great if everybody that's middle-aged and Caucasian gets this disease. And we're like, oh, yeah, well, that's not what we're trying to get. And so we iterated with a group of patients, both in person and online, until we got this. It's okay, and if that was the worst thing that we got, then we knew that what we were going to do was at least not going to be offensive, and on the other end of the spectrum, hopefully very, very good in terms of the way it resonated with the community. And so far, it's been amazing. We've had over 2,500 women and men with metastatic breast cancer sign up and become part of this project. They pressed, count me in, I want to contribute to this. They're from all 50 states. We have people from all over the world that signed up for this project. Right now, we're limited with where we can get tissue and saliva, but we hope one day to expand so that we can include everybody in this study. And we're learning a tremendous amount from the patient-reported data. Now, take a second and think through what it would take to parse through 2,500 medical records in order to figure out even the simplest question, like, how many of these people are HER2 positive? That'd be tough, right? 2,500 medical records. But if you just ask patients a series of questions beforehand, they self-identify a lot of information that's critical to our understanding of who is in the study. One of the things that we're exceedingly interested in are people who have had exceptional responses to therapy for the reasons that I had touched on before. So we asked them, have you been on any therapy for 2 years or greater? And if so, have you had an exceptional response? And we define what that is with the definition that patients gave us. And it turns out that there's a large swath of people who have had exceptional responses, and they've had them to different types of therapies. So you could never find at any one institution 117 people who've had exceptional responses to Xeloda. That would never happen. There's no mechanism for us to call up Dana-Farber and ask them to go through their records and find that information out. But now they're part of the study. And so we can build cohorts of people who have had exceptional responses to different types of therapies and really drill down on what are the molecular reasons or the footprint that is underlying that response. And the patients that we engage with are not, they're the drivers of this entire project. They aren't samples, as I mentioned in my very first slide. You can see here, this was San Antonio Breast Cancer Conference. Nick Wagley is the PI of this study. He's right there. And he sent out a tweet. He said, hey, if anybody's here, patient, advocate, we'd love to just chat with you. And we didn't think twice about it, but we ended up at this round table. So it was literally a round table. Everybody was contributing the same ideas. And we just brainstormed, like, what's the next thing? Where can we take this project next? This is an evolving thing. What would be impactful for you? What would be impactful for us? And out of this discussion with these patients, all sitting around the same table, came the operational plan for the next phase of this project, which is to collect blood biopsies from patients remotely and do whole exome sequencing of the entire tumor genome straight from their blood. So we actually have a couple patients consented to our pilot right now, and we've designed the kit and we're getting ready to send them out this week. So really exciting for us because we could be in a position where we could move away from tissue altogether, study mechanisms of resistance, do all discovery work just from blood. We ask our patients who are highly engaged in the process of helping us design this project to present it with us at the conferences. So this was ASCO this year, and this is one of our patients that came and presented our poster. And when she talked to people, it was an unbelievable connection between the patient and the oncologists and the other people and the reporters that came to see what was going on. And I'll tell you what, she did a better job than Nick and I could have ever done. She understood everything about this project. So the Broad Institute wants to do this, they want to branch out into other cancers, and they were considering rare cancers for a lot of obvious reasons. Just like you can't find 117 people with Xeloda at any one institution, you could never find people with rare cancers in the size large enough to properly study at any one institution. There's a great potential for large impact. The sell that I usually give to my scientific colleagues is, you want a paper? Pick any rare disease, and you do a decent job, and it's going to be mid or high level impact. So that's my David Letterman pitch that I give to them. And so it may not come as a surprise, but the first rare cancer that we're going to study is Angiosarcoma. It is, by definition, a rapidly proliferating, extensively infiltrating malignancy of the endothelial cells, so the inner lining of your blood vessels. So although it is a solid tumor, it acts almost like a blood cancer because it doesn't have to come to the same mechanisms of crawling through tissue and breaking down the extracellular matrix in order to metastasize. Typically, people that get this disease are already metastatic, and it can happen at any point in your life and any part of your body. I asked my Facebook group if they would be willing to consent to this study, and also if they were alive and living with the disease, because the vast majority of people in our 2,500 cohort Facebook group now are dead, or they're loved ones of people who have died or are dying. And in 1 hour, I had 92 people say, yeah, I'm still here, and I'll take part in this. And if we study those people, that will be the largest study ever done on an exceedingly rare cancer like this. And so the Broad said, sure, go for it. And so we've built the Angiosarcoma project, and we're launching it in a month with our advocacy partners that are in this space. And we hope to start enrolling people in the next month. We hope to start releasing our first data for the Metastatic Breast Cancer Project In this winter coming up, whether we've published or not, it's more important for us to get the data out than it is to have publications at this point. And then we hope to launch our next Broad direct-to-patient initiative in 2017. Patients, and this goes back to Pedro's talk as well, are the biggest stakeholders in our collective effort to thwart disease, And we can bring so much to the table, whether it's by making devices to help ourselves, whether it's making patient groups that we are the most invested people in across the board. We're there. We couldn't do our work if it wasn't for the patients and with our advocacy partners. For the Metastatic Breast Cancer Project, we have 20 groups now that are part of this, that are helping us get the message out. And tons of people that have come to work on this project. Nick Wagley is the PI. I want to thank the MBC Project patients and the Angiosarcoma Facebook group, and Lauren Ryan, who started everything for me. So thank you. Anybody have any questions? Yeah. Are you looking also at We have to stay pretty focused right now on the genomics and epigenomics of the disease. But with that being said, we would love to have an epidemiologist join our team at some point. And because of the way that we've constructed our consent, we can go back and ask these questions prospectively. I hope so. In our group, if we get clinical tests, we just share them with each other. We basically crowdsource each other's foundation reports, stuff like that. So we know each other's clinical data already. That's outside the boundaries of what we're consented allowed to do. But in rare disease communities, you see that usually happen organically. Well, this is largely patient-driven. So a patient signs consent to us, which allows us at the Broad to call on their behalf. We do everything. Exactly. No, so part of what we did in terms of talking with patients, my experience as a patient was we put the barrier to participate, both for the patient and their entire medical team, as low as possible. You know what I mean? Like, you don't memorize this new password, don't go to this new place. It's in their Facebook feed or it's in their Twitter feed, and it's as easy as possible. And then we do the work, so we make sure that we get stuff. Thank you. Yeah, so we have a website dedicated to the project, and we are in a constant iterative process with patients. We're trying to build out educational materials to help people understand what is a gene, what is DNA, or point them in a direction with where they can get that information. And right now, the way that we do this is largely through social media. So people ask us questions all the time. We have Twitter chats often. We solicit ideas, feedback, questions from people, and then put a blog post out explaining it, or put it out in social media explaining it. We're just starting to make YouTube videos explaining these things, so that people, and we crowdsource the questions and what they are and where the questions are, and find a variety of different ways to get the information out. Okay, thank you.